Hi, I'm Dan Gilden. I'm the program director at Legacy. Today we're going to be doing a presentation of the preliminary program. So Legacy is a 7-hospital system, of which the residency program occurs at 2 of the hospitals, Emmanuel and Good Samaritan. So why should I work at Legacy? Our internal medicine residency is one of the largest nonprofit community programs on the West Coast, and we offer a very intense opportunity to do training during your 1 year. So what is Legacy? As I said, it's a 7-hospital system. There's Good Samaritan Hospital, which is on the northwest part of Portland, which traditionally has been where the fanciest restaurants have been. That has kind of changed more recently, and that the more hip restaurants are actually now more towards Emmanuel Hospital, which is where we are today, which is in Northeast Portland and is the most diverse part of the city. Also on campus downtown is Randall Children's Hospital, which is one of the 2 children's hospitals in Portland. There's 4 other hospitals that Legacy runs. One is Mount Hood, which is in the east part of Portland. One is in Salmon Creek, which is in southwest Washington. One's Meridian Park, which is in the southern part of Portland. And one's Silverton, which is down by Salem. The residency, as I said, is run out of 2 hospitals. One of those is Good Samaritan Hospital, which is really your basic community hospital. Very high Medicare population. We actually run an inpatient geriatric service there. We have a consortium with OHSU that does oncology as a group project rather than us competing with OHSU about who could say that they're doing better cancer care. Instead of doing that kind of competition, we're actually working together, and OHSU oncology is on site at one of the Legacy hospitals at Good Sam. Emmanuel Hospital is really the county hospital for Portland. There is no county hospital system in Portland that rivals things like San Francisco General or Harborview in Seattle. There is no system like that. So patients go where they go. When you're going around town, you're going to find that every place you go says, we do underserved care. Well, that's true because since there's no county hospital system, patients go where they go. But because this is the most diverse part of the city, they come to mainly Emmanuel Hospital, and the other place they actually go to is Mount Hood Hospital out in Gresham, because again, that's a very underserved community. When you look at underserved care within Portland, it's not even close. Legacy is doing way more than anyone else. Now, the other thing about Emmanuel is that we're taking care of the sickest patients in the city. We have 2 level 1 trauma centers in Portland. One is at Emmanuel and one is at OHSU. But in an odd way, the Regional Burn Center for all of Southwest Washington and Oregon is at a private hospital, which is Emmanuel. So that's a very unusual situation. Usually you think of it as being the county hospital like Harborview or someplace like that, not in a private hospital. But it's been here for about 50 years, and it really brings in a lot of sick patients that you wouldn't necessarily think about because they see a lot of non-burn cases, such as necrotizing fasciitis, Stevens-Johnson syndrome. So if anyone's interested in dermatology, for instance, and wanted to do a burn rotation, that would be available to them. We're also one of the largest adult ECMO centers on the West Coast. During H1N1 from 2009, we were running upwards of 6 patients on ECMO at a time. So what happens is, because we're doing so much intense care, these places that are used to sending in sick patients to Portland, they're sending them to Emmanuel because that's been their referral pattern. And so we're really by far taking care of the sickest patients in town. The residency program. So this is a community hospital with 2 high-volume centers. We have a group of residents that our goal is to work very hard while you're here and then get out. And our goal for the 1 year is for you to get a very intense experience, be very good at internal medicine as an intern, and then go on to whatever career opportunity you have. So the program directors, so Dr. Deering is the program director for the preliminaries. She will be doing half of the interviews today. When we're on Skype, it'll be Dr. Deering, myself in the room, along with interns, and then at the end of the Skype presentation, there will be some time for the intern to talk with the applicant, with us out of the room. I've been the program director at Legacy since 2011. Dr. Folger is one of the associate program directors. She's a geriatrician. She will not be doing any interviewing today. Dr. Mankin is an outpatient doctor, is one of the program directors, and he's responsible for academic half day, which is our education opportunity. Dr. Minter is one of the associate program directors, and she is responsible for evaluations, and Dr. Estabrook does our medical students. The other 2 people that will be interviewing today will be general faculty members. We have a group of very happy residents. We'll never show you slides of people that are unhappy. So this is what the work looks like. And don't write this down. This is a template. There might be some slight differences year to year. So basically, we run everything on a 3+1 model. So that means that when you're on a ward block, you do 3 weeks of inpatient and 1 week of clinic. As a prelim, you will still do regular clinic the same way as a categorical intern. In fact, your rotations will be absolutely identical to the categoricals, except the prelims get 1 or 2 electives, and the categoricals, we give them pulmonary, geriatrics, and the transitions of care week. So the only difference is you get a couple of blocks of elective time, 1 or 2 blocks, and the categoricals, we actually give them rotations. So what does it look like? You will do about 5 ward blocks split between Emmanuel and Good Samaritan. There'll be a couple of ICU blocks. There'll be a couple of night medicine blocks, a block of clinic, and a block in the Emmanuel ER. The wards are 1 resident, 1 intern teams. Now, when you go around interviewing, you're going to find that some places are starting to decrease the ACGME caps. So an ACGME cap for a 1 resident, 1 intern team is 14. When you go around, you're going to see some people that are modified that down to 10 or 12. That's not what we're planning on doing, because our goal every day is for you to see 9 to 11 patients. We consider that the sweet spot for residency training. If you lower it to 10, that means sometimes you might be seeing 5 or 6 patients, which is not enough of an experience. So our cap is 14. Do we sometimes hit that cap? We do. But your resident helps you, your attending helps you, we make it through, but we ensure that every day is a quality educational experience. So on the wards, we have medical students on all the teams. At any given time, we have 5 third years at Good Sam, 5 third years at Emmanuel. 3 of those on each side are OHSU, 2 are Western Osteopathic. Then we also have 4th year students that are rotating through on ICU and on the ward services. Now, the ward structure is long shift, short shift, short shift. So it's every third but it's not every third night call. Nobody in our program works more than 14 hours shifts. So there's no such thing as running a 24-hour or 26-hour shift. We don't do that. And we have no plan on doing that. I know ACGME has said it's fine to do that to interns. We've decided that it's not okay for anyone, because we don't think that anyone is better in hour 24 than they are in hour 2. And so our goal is to work you hard while you're here, have you get the same kind of experience you might get in 26 hours, but give it to you in a much shorter period of time. So we'll go into how we're able to do that later. All of our wards are done, multidisciplinary, and you'll be working almost all the time with one hospitalist for the week who will be seeing almost all of your patients. So it's not like you have 10 different attendees. ICU is a similar structure. It's one resident, one intern, but we only have 2 teams that are on. So you're running long, short, long, short. But again, you're not spending more than 14 hours in the hospital. We have made some slight modifications about our caps in the ICU. ACGME doesn't have a defined cap in the ICU. So a couple of years ago, in the Emmanuel ICU, those 3 to 4 residents were seeing upwards of 22 patients on a day. Well, if you think about that, if you're rounding on 22 patients and it takes you 15 minutes per patient to round, you're suddenly rounding for 6.5 hours and you haven't done anything yet. And so we did modify that down to 15. So the ICU team started a max of 15. During the day, they can go up to a max of 20. And so that actually has worked out very well. It's well within what the residents feel comfortable with, and it does deal with mostly the plurality of the ICU cases. There's high procedure volume. In our categorical program, we've had a number of people do upwards of 50 or more central lines while they're here. So there are plenty of opportunities. When you go on your tour today, you're going to find that the ICUs look brand new. And they are very new. They're only a few years old. But they're going to be mothballed in a few years because new ICU tower is being built. But that obviously will not be available to you during your internship here. There's ultrasound training available as well, especially in the ICU, where a number of the ICU docs are quite facile in that, and likewise a number of the hospitalists are becoming facile. The house staff are responsible for all codes in the hospital, and then there's sim lab training as well. So night medicine is our key to how we make it so that you're only working 14 hours. So you do this by working hard at night so that everybody else is sleeping at night. And so at any given time, we have 3 teams of 1 resident, 1 intern that are on night medicine. And let's just take one team, for instance. So let's say there's a team that's got 4 nights at Good Sam. They'll have 2 nights off, 4 nights at Emmanuel, 2 nights off, 4 nights at Good Sam, and rotate through the month that way. What that turns out to be is you're working 2/3 of the nights, and in terms of workload, the Good Sam nights are usually busy but not overwhelming. The nights off are obviously pretty good, and then you have the Emmanuel nights, which can be very busy. Now, there is help. We have ICU docs in-house until midnight, and they're totally open to coming in at 1 a.m., 2 a.m., etc. And we also have 24/7 hospitalists in-house. But why is this so busy? Well, as I said, the ICU might have 20 patients in there. The senior resident at night is covering the ICU. The intern, i.e. you guys, and if each team at Emmanuel, we'll say, or Good Sam has 10 per team, you as the intern are going to be covering 30 ward patients. Plus, there's going to be admissions from the emergency room. So it's daunting the first time you do it. The second year residents are scared, but then once they've done it, they go, wow, that was a great experience. And it actually turns out that night medicine is one of the rotations that the residents end up liking the best in the long run, because at some point you need to get stressed in terms of what you're able to do, and this is a rotation that allows you to make decisions to get to the point of working at your limit, but we never want people to work over their limit. So that's our goal on night medicine. Our plan is not to bring more people in at night. I mean, we could make it so that the experience was less intense at night, but that means you have more residents in-house, and that means you're affecting all other educational activities. Likewise, having people spend all night in the hospital is a horrible way of doing education the next day. It's not a good way of doing medical care the next day. We'd rather have people come in, work hard at night, and then get out. Our plan, if it were to get more busy at night, is not to have more residents do it. It is to have more coverage from ICU and hospitalists that are being paid at night to be here, not by making their house staff work even harder. Continuity clinics. So there's a clinic on each side. Everything is done in a medical home model. You'll do clinic in this model. You will have probably not very many continuity patients, but inevitable that you will see patients repeatedly during your internship. And again, you will have a clinic block month as well as +1 week throughout your year here. The education. As I said, we have academic half day. So on Wednesdays at 9 a.m., all of the senior residents leave where they are and they come to Emmanuel for academic half day. So that is 2 hours of didactics and then an hour of fun, which is cases or journal club. Then the whole residency convenes at Grand Rounds, and then in the afternoon, it's intern academic half day, where the first hour is fun, which is cases, and then a couple of hours of didactics. And so we don't have noon conferences on other days. Everything is really on Wednesdays. We also have morning reports. The night medicine intern will present a case to the oncoming teams that they admitted the night before. Because the team is going to have to hear about that anyway, and it gives a chance to talk about one of the good cases they admitted overnight. On Tuesdays, I meet with the teams at Emmanuel, and we go over one of the cases that they have on their service, and we call that Chief of Service Rounds. There's an outpatient medicine curriculum that you'll have when you're on +1 weeks in clinic block, which we purchased from Yale, and we present whatever their weekly curriculum is for that week. We have a number of visiting professors. I know we have one here, a student here today from UCSF, and there's a famous UCSF doc named Gurpreet Dhaliwal, who's one of the best case discussants in the world. And in fact, he presented a case in the New England Journal last week. He was the discussant on that case. He only does a couple of visiting professorships a year in the world, but he comes here every year. And this is one of his favorite couple of days that he does all year long. And so his plan is for him to continue coming and being a part of the program. We also have other visiting professors throughout the year. Okay, what else do we have going on? Oops, sorry about that. The first thing is grit. So what is grit? Well, this won't actually affect you very much because the prelims will not do grit. But what we've done is for the categoricals in 2 of the blocks, block 11 and block 13, we change our ward structure so that two interns are working together with no senior resident. So that is practice for them being second-year residents. Then we also change wards during those times that the third-year residents are working one-on-one with a hospitalist so that they are practicing being an attending. So it's taking some of the discontinuity out of training and making it so that it's more continuous. For the prelims, what that means is you will be doing wards with one resident, one intern teams in blocks 1 through 10 and block 12, and you won't be on blocks 11 or 13 on wards. You could still be on night medicine or in the ICU. Everyone gets access to PaperPile, which is an online PDF format that allows you to store articles without cutting them out and putting them in manila folders. As I said, there's an outpatient medicine education that we purchased from Yale. There's one other thing that we're going to be putting into the program that won't affect you, but sort of tells you how the program is morphing over time, and that is we're going to start requiring our residents to complete Suboxone training. So we will be paying for their training. They can decide whether they want to get the Suboxone waiver or not, but everyone will go through maintenance training with Suboxone and methadone, and then how to do outpatient prescribing with Suboxone, because no matter what you go into now, you think that, oh, I'm going to go into anesthesia, that's not going to be an issue with me. Well, it turns out that there's a big issue in terms of how do you do anesthesia on somebody who's on Suboxone. So there's lots of issues that no matter what you go into, it's going to affect your practice. And so we are making this an essential part of our program. At this point, we're not going to require prelims to do the training. So as I said, our goal is for you to work hard and play hard. Our longest shift is 14 hours. There's 4 weeks of vacation. So over the holidays, Christmas, New Year's, what we do is we divide the residency in half. So half works Christmas week, half works New Year's week. And so there's no education during that time, there's no morning report, it's get the work done and do your team rounds, etc. And then the next week you will be off, and then you get 3 additional weeks of vacation during the year. We have a wellness program that we share with OHSU. So we used to have a psychologist as part of the program. He retired. Instead of hiring another psychologist, we purchased through OHSU the ability to send our residents to their wellness program. They have an incredibly rich program, and the people that run that program come down and give us education. It allows you to get any kind of counseling you need. We have no idea if you've been there, and it's absolutely free for you as well as confidential. We have quarterly retreats. As you can see here, there's a group of residents and an attending walking through the Columbia River Gorge. You won't be able to do that because the Columbia River Gorge burned up this last year because a 15-year-old lit off a firecracker or something like that and burned the gorge, and it's not clear when that's going to reopen. Like I said, we have other retreats as well. One was done recently on cultural diversity. There'll be communication ones. We run sort of 3 academic retreats during the year and 1 sort of fun hike. So after the retreats, we do different events. In the upper corner here, it's curling. We've gone curling a couple of times. And then in the very bottom, there's a intern raft trip just before you start to have you bond together. That's in about 34-degree water. So I hope you have fun. So the benefits. So the pay for 2016 was $56,750. 2017 it was $58,169. So you can see it went up by $1,300 or so. I don't know what the salaries will be for 2018 and beyond, but you can see that it probably goes up by about 1,000 or so per year. If you were to stay here for residency, again, going from PGY1 to PGY2 would be another bump of 1,500 or so. The national average is about 53,000, so we are well above that. There is comprehensive medical insurance, including free dependents. So even though you're spending no shifts longer than 14 hours in the hospital, we do cover almost basically all your meals. So you will get meal cards that give you about $1,000 or so of food, and that should cover all of your meals that you would have here, unless you decided to live here and eat all your meals in the cafeteria, which I would not recommend. Parking is free, and then we also have this incredible deal with LA Fitness that saves you 50 cents or $1 a month. I tried to get, I know millennials like to climb rocks, so I tried to get, there's a place called Planet Granite, and I tried to get a decreased membership at Planet Granite, but because there's so many millennials that like to climb rocks, they were not interested in giving us a break. So the city, so Portland is much cooler than a lot of cities because, like in the right upper corner, you can see a big mountain. So that's Mount Hood. You're not going to see it a lot of times in Oregon because it's raining all the time. But when it's sunny out, it's really beautiful. And what's cool about it is you know which mountain it is. Whereas if you're in the Alps or the Himalayas or the Rockies, you don't know which mountain you're looking at because they all look alike. But in Oregon, you don't see anything and then suddenly there's a volcano. The other thing that's cool is Portland really is the #1 bike city in the country. Where we are right now in Northeast Portland is sort of the center of the bike culture in Portland, and about 13 or 14% of all commutes downtown from Northeast Portland are by bike. In the summer, for the entire city, it's around 8 or 9%, which is much better and much higher than any other city in the country. We are a long way from being Amsterdam. So why should I work at Legacy? So we have a very cohesive group of residents, faculty, and program directors. There's top quartile pay. You get 4 weeks of vacation, including a week over the holidays. Thank you and have a great interview.